Aortic valvular stenosis. Jeremy Golding, MD, FOF. Basics. Description: aortic stenosis, as, is a narrowing of the aortic valve area causing obstruction to left ventricular, LV, outflow. The disease has a long asymptomatic latency period, but development of severe obstruction or onset of symptoms such as syncope, angina, and congestive heart failure, CHF, are associated with a high mortality rate without surgical intervention. Epidemiology: as is the most common primary valve disease leading to surgery or catheter intervention in Europe and North America, with a growing prevalence due to the aging population. 1. Cause by age at presentation: 30 years, congenital 30 to 65 years, congenital or rheumatic fever, RF, greater than 65 years. Degenerative calcification of aortic valve prevalence affects 1.3% of population 65 to 74 years old, 2.4% 75 to 84 years old, 4% greater than 84 years old. Bicuspid aortic valve, 1–2% of population. Bicuspid aortic valve predisposes to development of AS at an earlier age. Etiology and pathophysiology: progressive aortic leaflet thickening and calcification results in LV outflow obstruction. Obstruction causes increased afterload and, over time, decreased cardiac output. Increase in LV systolic pressure is required to preserve cardiac output. This leads to development of concentric LV hypertrophy, LVH. The compensatory LVH preserves ejection fraction but adversely affects heart functioning. LVH impairs coronary blood flow during diastole by compression of coronary arteries and reduced capillary ingrowth into hypertrophied muscle. LVH results in diastolic dysfunction by reducing ventricular compliance. Diastolic dysfunction necessitates stronger left atrial, LA, contraction to augment preload and maintain stroke volume. Loss of LA contraction by atrial fibrillation can induce acute deterioration. Diastolic dysfunction may persist after relief of AS due to the presence of interstitial fibrosis. Angina, increased myocardial demand due to higher LV pressure. Myocardial supply is compromised due to LVH. Syncope, exertional can be multifactorial from inability to augment cardiac output due to the fixed obstruction to LV outflow, arrhythmias, or most commonly, abnormal baroreceptor response resulting in failure to appropriately augment blood pressure. Heart failure, eventually, LVH cannot compensate for increasing afterload resulting in high LV pressure and volume, which are accompanied by an increase in LA and pulmonary pressures. Degenerative calcific changes to aortic valve. 2. Mechanism involves mechanical stress to valve leaflets as well as atherosclerotic changes to the valve tissue. Bicuspid valves are at higher risk for mechanical stress. Early lesions, subendothelial accumulation of oxidized LDL and macrophages and T lymphocytes, inflammatory response, disease progression, fibroblasts undergo transformation into osteoblasts. Protein production of osteopontin, osteocalcin, and bone morphogenic protein 2, BMP2, which modulates calcification of leaflets. Congenital, unicuspid valve, bicuspid valve, tricuspid valve with fusion of commissures, hypoplastic annulus RF, chronic scarring with fusion of commissures. Risk factors. Congenital unicommissural valve or bicuspid valve. Unicommissural valve, most cases were detected during childhood. Bicuspid valve, predisposes to the development of AS earlier in adulthood, 4th to 5th decade, compared to tricuspid valve, 6th to 8th decade. RF prevalence of chronic rheumatic valvular disease has declined significantly in the United States. Most cases are associated with mitral valve disease. Degenerative calcific changes. Most common cause of acquired AS in the United States. Risk factors are similar to that of coronary artery disease, CAD, and include the following: hypercholesterolemia, hypertension, smoking, male gender, age, and diabetes mellitus. Commonly associated conditions: CAD, 50% of patients; hypertension, 40% of patients results in double-loaded left ventricle, dual source of increased afterload as a result of obstruction from AS in hypertension; aortic insufficiency, Common in calcified bicuspid valves and rheumatic disease, mitral valve disease. 95% of patients with S from RF also have mitral valve disease. LV dysfunction and CHF acquired von Willebrand disease, impaired platelet function and decreased VWF results in bleeding, ecchymosis and epistaxis, in 20% of S patients. Severity of coagulopathy is directly related to severity of AS. Gastrointestinal arteriovenous malformations, AVMs, cerebral or systemic embolic events due to calcium emboli. Diagnosis. History. Primary symptoms, angina, syncope, and heart failure. Angina is the most frequent symptom. Syncope is often exertional. Heart failure symptoms include fatigue, exertional dyspnea, orthopnea, paroxysmal nocturnal dyspnea, and shortness of breath. Palpitations. Neurologic events, transient ischemic attack or cerebrovascular accident, secondary to embolization. Geriatric patients may have subtle symptoms such as fatigue and exertional dyspnea. Note: symptoms do not always correlate with valve area, severity of AS, but most commonly occur when aortic valve area is 1 cm 2, jet velocity is greater than 4.0 m/s, or the mean transvalvular gradient is greater than or equal to 40 mmHg. Physical exam. Auscultation. Harsh, systolic crescendo-decrescendo murmur is best heard at second right sternal border and radiates into the carotid arteries. Peak of murmur correlates with severity of stenosis. Later peaking murmur suggests greater severity. High-pitched blowing diastolic murmur suggests associated aortic insufficiency. Paradoxically split S2 or absent A2. Note: normally split S2 reliably excludes severe AS. S4 due to stiffening of the left ventricle. Other associated signs include pulsus parvus et tardus, decreased and delayed carotid upstroke. LV heave, findings of CHF, pulmonary and/or lower extremity edema. Differential diagnosis. Mitral regurgitation, high frequency, pansystolic murmur, best heard at the apex, often radiates to the axilla. Hypertrophic obstructive cardiomyopathy, also systolic crescendo-decrescendo murmur but best heard at left sternal border and may radiate into axilla. Murmur intensity increases by changing from squatting to standing and/or by Valsalva maneuver. Discrete fixed subaortic stenosis, 50-65% has associated cardiac deformity, patent ductus arteriosus PDA, ventricular septal defect VSD, aortic coarctation. Aortic supravalvular stenosis, Williams syndrome, homozygous familial hypercholesterolemia. Diagnostic tests and interpretation. Initial tests, lab, imaging, chest X-ray, CXR, may be normal and compensated. Isolated valvular as boot-shaped heart reflective of concentric hypertrophy. Post-stenotic dilatation of ascending aorta and calcification of aortic valve, seen on lateral PA. CXR, ECG, often normal ECG. ECG is non-diagnostic, or may show LVH, LA enlargement, and nonspecific ST and T wave. Abnormalities. Echo indications. Initial workup. Doppler echocardiogram, primary test in the diagnosis and evaluation of AS. 1. A assesses valve anatomy and severity of disease. Assesses LV wall thickness, size, and function, and pulmonary artery pressure in known as and changing signs/symptoms in known as and pregnancy due to hemodynamic changes of pregnancy. Echo findings. Aortic valve thickening, calcification, decreased aortic valve excursion, reduced aortic valve area. Transvalvular gradient across aortic valve. LVH and diastolic dysfunction. LV ejection fraction. Wall motion abnormalities suggesting CAD. Evaluate for concomitant aortic insufficiency or mitral valve disease. As severity based on echo values. 2. Stage A, at risk bicuspid aortic valve, sclerosis, or other congenital abnormality, mean pressure gradient, 0 mm Hg, jet VEL. 2M/S. Stage B, progressive bicuspid or tri-leaflet valve, mild, mean pressure gradient, 20 mm Hg, jet VEL. 2.0 to 2.9 M/S. Moderate, mean pressure gradient, 20 to 40 mm Hg, jet VEL. 3.0 to 3.9 m/s stage C, asymptomatic severe as C1, without LV dysfunction AVA less than or equal to 1.0 or AVAI less than or equal to 0.6 cm2/m2, mean pressure gradient, 40 to 60 mm Hg, jet VEL. Greater than or equal to 4 to 5 m/s C2, with LV dysfunction AVA less than or equal to 1.0 or AVAI less than or equal to 0.6 cm2/m2, mean pressure gradient, greater than or equal to 40 mm Hg, jet VEL. Greater than or equal to 4 m/s stage D, symptomatic severe as D1, high gradient AVA less than or equal to 1.0 cm2, mean pressure gradient, greater than 40 mm Hg, jet VEL. Greater than 4 m/s D2, low flow/low gradient with reduced F50% AVA less than or equal to 1.0 cm2, mean pressure gradient, 40 mm Hg, jet VEL. 4 m/s D3, low gradient, normal F greater than or equal to 50% or paradoxical low flow severe as AVA less than or equal to 1.0 cm2, AVAI less than or equal to 0.6 cm2/m2 and stroke volume index 35 ml/m2, mean pressure gradient, 40 mm Hg, jet VEL. 4 m/s diagnostic procedures/other exercise stress testing asymptomatic patients with severe AS, helpful to uncover subtle symptoms or changes, abnormal BP, increase 20 mm Hg, and ECG changes, ST depressions. 1/3 of patients develop symptoms with exercise testing, stop testing at this point. Symptomatic patients, do not perform exercise stress testing because it may induce hypotension or ventricular tachycardia. CHF patients, dobutamine stress echocardiography is reasonable to evaluate patients with low flow/low gradient as an LV dysfunction. Cardiac catheterization performed prior to aortic valve replacement, AVR, in patients with suspected CAD. Determines need for coronary artery bypass graft, CABG. If unambiguous diagnosis of AS, perform only coronary angiography. Can also use if non-invasive testing is inconclusive or if there is discrepancy between severity of symptoms and findings on echo measures transvalvular flow and transvalvular pressure gradient, which facilitates calculation of effective valve area. Hemodynamic measurements with infusion of dobutamine can be useful for evaluation of patients with low flow/low gradient as an LV dysfunction. Test interpretation: aortic valve, nodular calcification on valve cusps, initially at bases, cusp rigidity, cusp thickening, and fibrosis. LVH, myocardial interstitial fibrosis. 50% incidence of concomitant CAD treatment. Medication: no effective medical therapy for severe or symptomatic as prevention, currently no recommended medical therapy. Statins have been thought to slow progression if initiated during mild disease. However, this has not been supported by large, randomized controlled trials. Antibiotic prophylaxis against recurrent RF is indicated for patients with rheumatic AS, penicillin G 1,200,000 UIMQ4WK, duration varies with age and history of carditis. Antibiotic prophylaxis is no longer indicated for prevention of infective endocarditis. Comorbidities: hypertension, angiotensin-converting enzyme, ACE, inhibitors. Start with low dose and increase cautiously. Be cautious of vasodilators, which may cause hypotension. Surgery/other procedures. AVR is recommended for most symptomatic patients with evidence of significant AS on echocardiography. 3. Indications for AVR surgery: symptomatic and severe high gradient AS by history or exercise testing. 2. B when surgical risk is low or intermediate asymptomatic, severe AS and LVEF 50%. 2. B severe AS, stage C or D, when undergoing other cardiac surgery. 2. B AVR surgery is reasonable in patients who are asymptomatic with severe AS, C1, with jet VEL greater than or equal to 5 m/s and low surgical risk, decreased exercise tolerance, or have an exercise fall in blood pressure. 2. B. Symptomatic stage D2, with a low-dose dobutamine stress with jet VEL greater than or equal to 4.0 m/s or mean pressure gradient greater than or equal to 40 mmHg with less than or equal to 1.0 cm2 at any dobutamine dose. 2. B. Symptomatic stage D3 with LVEF 50% if clinical and hemodynamic data support valve obstruction as likely cause of symptoms. 2. C. Stage B who are undergoing other cardiac surgery, or asymptomatic stage C1 with rapid disease progression and low surgical risk. 2. C. Alert note: if the aortic valve area is greater than 1.5 cm2 and the gradient is 15 mm Hg, there is no benefit from AVR. Transcatheter AVR, TAVR, offers a less invasive option for some patients. 1. For those who are high at surgical risk and considered inoperable, TAVR has demonstrated superiority to medical therapy. For those who are high at surgical risk, TAVR has demonstrated non-inferiority to surgical AVR. 1. For those who are intermediate at surgical risk, TAVR may emerge as a reasonable alternative to surgical risk, although this indication has not yet been approved in the United States. Valve-in-valve TAVR can be considered in high-risk patients with failed surgically implanted bioprosthetic valves. Percutaneous balloon valvuloplasty may have role in palliation or as a bridge to valve replacement in hemodynamically unstable or high-risk patients but is not recommended as an alternative to valve replacement. Ongoing care follow-up recommendations advise patients to immediately report symptoms referable to AS. Asymptomatic patients, yearly history and physical serial echo, yearly for severe AS, every 1 to 2 years for moderate AS, every 3 to 5 years for mild AS. Patient education. Physical activity limitations. Asymptomatic mild AS, no restrictions. Asymptomatic moderate to severe AS, avoid strenuous exercise. Consider exercise stress test prior to starting exercise program. Prognosis. Although survival in asymptomatic patients is comparable to that in age and sex-matched control patients, it decreases rapidly after symptoms appear. 3. 25% mortality per year in symptomatic patients who do not undergo valve replacement. Average survival is 2 to 3 years without AVR surgery. Median survival in symptomatic AS, heart failure, 2 years, syncope, 3 years, angina, 5 years. Perisurgical mortality. AVR surgery has 4% mortality rate, AVR and CABG has 6.8% mortality rate. Adverse postoperative prognostic factors. Age, heart failure. New York Heart Association, NYHA, Class 3/4, cerebrovascular disease, renal dysfunction, CAD reference.